Our next speaker is James Gilbert. He's a consultant transplant and vascular access surgeon at Oxford University Hospitals. Now, James is the president of the Vascular Access Society. He leads the vascular access program in Oxford. He's going to be talking about new methods and his experiences. Now, I've seen James talking before, and it is absolutely fascinating. So over to you, James.
Well, good morning to you all. Well, it's nearly the end of the morning, may even be afternoon. Good afternoon to you all. A huge thank you to the National Kidney Federation for asking me to contribute to this really exciting patient day. I'm James Gilbert. I'm a transplant and access surgeon in Oxford, and I've been asked to talk to you a little bit about endovascular arteriovenous fistulas for dialysis. I have a few disclosures to bring to your attention as I start, and I think the big disclosure is that in my talk, I've got a number of clinical pictures of fistulas, some that look nice, some not so nice. So if you're squeamish, I'm just giving you that information now. As I do start, I want to say a huge thank you to all of you. As a clinician, I absolutely love doing the job I do as a transplant and access surgeon. And that's because of working alongside many, many patients like you. We as clinicians couldn't do what we do without your input, without your feedback, without your partnerships. And I think that's one of the great things about kidney disease, managing patients with kidney disease, that we work in a partnership and you are seen as equally important to that from our perspective. So thank you for all that you do and for all your contributions to kidney care and also to today. Many of you will have seen this slide before, but what this slide is essentially showing is that in the years gone by, the number of patients in the UK that are needing renal replacement therapy of some form is increasing year on year. And the different coloured lines here show those patients who are getting transplanted in the dark red, those who are on in-centre haemodialysis, those on peritoneal dialysis, and those on haemodialysis. And we know that for patients going on to dialysis, your outcome long-term, the longer you remain on dialysis, is not good for you. And this slide shows that here. It shows us that your survival over the course of time fares less well compared to somebody of the same age group who is not on dialysis. And depending on your underlying cause of kidney failure, you have a less good outcome longer term. So diabetics on dialysis don't do well the longer they remain on dialysis. And it's for that reason we are really keen that as patients come in to land on a dialysis machine and need to start dialysis, we ideally want to get them transplanted. And the thrust for many of the patients that we're looking after is we want to see if we can get a kidney transplant in as timely fashion as possible, ideally before they start dialysis or at least fairly soon after starting dialysis. Transplantation is not always possible, though, for some patients, and it's not always possible at the point you need to start renal replacement therapy. And in that situation, we need to get access in place so that you can have dialysis. One of the key things we need to decide on is what modality or type of dialysis you're going to have, whether it's haemodialysis or peritoneal dialysis. And if we're going to do haemodialysis, there needs to be some assessment undertaken regarding what is the right access for you. How do we start you on dialysis? What's the best thing to undertake for you? I'm a great believer that I want to avoid lines for dialysis as much as possible because we know that lines left in patients long term can cause problems. I don't have time in this talk to go into that, but that is something we do know. And that's one of the reasons we very much look to try and get fistulas created for patients if they're going to have haemodialysis. So if you're a patient who decided you are going to have haemodialysis, some other things we might think about, is it going to be in hospital or at home? There's no right or wrong around that. We need to look at what's the best option for you as a patient, take into account things like your home situation, your work, family support. Other things I would contemplate is, are you left-handed or right-handed? The reasons for that is if you do home dialysis and you need to cannulate yourself, you want to be able to cannulate with your dominant hand. Are you still at work, as I've said, factoring dialysis sessions around your employment so that we can maintain as much quality of life as possible, despite the challenges of having to start haemodialysis? We need to have a look at whether you can actually have an arteriovenous fistula, and if so, what kind could we create? We classically look at whether we can create a fistula at the level of your wrist, the so-called radiocephalic fistula, whether we might do it at the elbow region, a brachiocephalic fistula, or whether we have to start looking in your upper arm at deeper veins and moving those veins around, a brachiobasilic fistula. Sometimes for some patients, they have no veins that we can use, and there isn't an arteriovenous fistula option, and we have to place an artificial vein or a graft and put grafts into patients. I'm very much a visual person, and so here are some pictures to kind of describe what we're meaning here. The pictures in these slides show wrist fistulas being created, the radiocephalic, or on the right of your slide, you can see a brachiocephalic fistula there, where a vein has been joined onto the side of an artery at the level of the elbow to get a fistula ready for dialysis. Sometimes there aren't simple veins to use in the arms, and we have to dig out the deeper vein sitting on the inside of your upper arm, the so-called basilic vein, and move that across from its deep position into a more superficial position so that the dialysis nurses can place needles. It's quite a big operation and a big undertaking, but this is what you're invariably left up with when you have that procedure. And as I mentioned, sometimes patients don't have veins that we can use, or they've exhausted all vein options by having lots of fistulas made over the course of time and need to have an artificial vein or a graft inserted into the arm. A graft relies on there being an artery at one end that can put flow into the graft, and then a vein somewhere at the other end that you can land that graft onto. And this is a four-arm loop configuration. But we can make grafts and place them in the upper arms as a straight configuration, or sometimes we can place them in the legs. Whatever we're doing though, whatever access we're looking to create, whether it's a simple fistula at the wrist or the elbow, a more complex movement of a deeper vein or a graft, we're trying to get access created so that patients can have needles put into those fistulas or grafts, and they can have blood taken out, put through a dialysis machine, and put back into the circuit repeatedly over a 4-odd hour period. We want to be able to get good pump speeds on a dialysis machine, and an underlying fistula working well will do that. We want to ensure that we've got good pressures on dialysis, the venous and arterial pressures, so that patients can process good volumes of fluid through the course of their dialysis episode and ultimately come out at the end of it with what we would term excellent adequacy. And by that, we mean being able to clear waste products really efficiently and any excess fluid that's on board during that dialysis session. We know that we can achieve that for patients if we have what I call a patent access circuit. And by that, I mean what you see in this slide here. This is a fistulagram that's been done. And what you can see at the very start of the fistula is flow going into the fistula vein and then running all the way freely up the arm through the central veins to the chest and back into the heart with absolutely no hold up to flow at all. I like cars, I like traveling, and I often use analogies of motorways. A good working vascular access circuit, fistula circuit, is one where you've got 4 lanes of motorway traffic that run freely with absolutely no hold up from the start to the finish of the route, as you see in this picture here. But sometimes fistulas don't work for patients. And when we look at the data out there, we can see that there is quite a high primary or early failure rate of fistulas that get created. Depending on what literature you read, that can be between 30 and 50% of patients. And I'm sure there's many of you out there who've had that experience. You've had a fistula made, it seemed to have worked at the time of creation, but within a few weeks it stopped working, or it may not have even worked from the outset. We also know that those fistulas we do get working at the time of creation, that a year on, the functionality of those fistulas isn't as high as we would like. They have patency rates that are only around 50 to 70%, and many patients are needing repeated procedures, and some of you will have gone through this, fistuloplasties, to keep that access working and running well. And if they do work, if these fistulas are working well, they can become quite large and unsightly. They require often regular maintenance to keep them in good working order. But they can also block off, they can bleed, and they can be lost. And here are just a few, slightly gory pictures of things that can happen to fistulas. They can become huge and aneurysmal. They can get blocked in the motorway, if you like, that leads to a build-up of pressure back in the arm, causing arm swelling. Or they can have problems around needling sites that can put them at risk for bleeding. So could there then be a better way to try and get fistulas or access made for patients that would have, if you like, better long-term outcomes in terms of patency, not needing interventions to keep it working, but also not becoming unsightly, swollen, aneurysmal, as you've seen in some of those previous pictures? Well, enter the role of the endovascular arteriovenous fistula creation. This is a relatively new and novel non-surgical approach to making fistula. It's done in a radiological department, and the way of making endovascular fistulas is one where we look to create a network of fistula veins in an arm rather than just a solitary fistula vein running up the arm. This may have some better outcomes, as I'm going to show you now. There are two devices available at the moment to create an endovascular fistula. There's one that's the wavelength system, and the other is the ellipsis system. They both have similar principles in what they're trying to achieve. These principles are essentially that we're looking to create an arteriovenous fistula network in the arm where we get fistula flow into as many of the veins as possible, the superficial veins as possible. And to do this, we need something called a perforator vein to be present in patients. Down in the level of the proximal forearm, there are a number of veins that come together superficially, and they're fed by a deeper vein, perforator, that enables venous flow to run from deep to superficial systems and vice versa. We can see that here in this slide. You can see the perforating vein being labeled with the purple arrows. And what happens with this perforating vein is it means that flow can move from deep and superficial veins in the arm. Approximately 75% of patients have suitable anatomy in their arms and have this perforator vein, and its presence means that you can potentially create endovascular fistulas. If you have a look at where that perforating vein is on the slide, you can see it sits very near to the adjacent arteries around that level, which is important when it comes to these endovascular fistula creations. Just introducing the wavelength system for you now. This is a system that's owned by BD Bard. It's a radiological system. And what we do with this is we place a couple of catheters, one into the radial artery and another into the vein that runs alongside it. These catheters are brought up to the level of the elbow region where that perforating vein sits. And the catheters have magnets on them that draw them together, and a little bit of heat is fired for about 2 seconds to create a hole between the artery and the vein that have been magnetized together. And it now means that arterial flow can go into this vein. Because it's just beneath the perforator vein, the flow then runs from this perforator and up into the superficial veins, making a fistula. The ellipsis system also works in a similar manner in terms of it requires this perforating vein to be available, and this video just explains this to you. Under ultrasound guidance, a needle is placed into a vein in the antecubital fossa. It's pushed down to where that vein sits near to the artery and advanced into the artery, and a guide wire is advanced down the artery, connecting the artery and the vein together. The ellipsis catheter is then put over the guide wire via a sheath which is just being inserted here. Here comes the catheter now for creating the fistula. It's got two components on it that pull together. And once you advance this into the artery and then remove the sheath, what you can actually do is create a hole between the adjacent artery and vein. And once that's been done, it will enable arterial flow to run into the adjacent vein. And again, because it's quite near to the perforating system, it feeds up into the more superficial veins of the arm, giving fistula flow in these superficial veins that can then enable the veins to mature and be used for dialysis. The two devices have a number of similar but also different properties. I won't go through all of them here. What I would highlight, though, is that the wavelength system, because of the way it's set up with the catheters, is it does mean you could create the fistula a whole different range of levels between the artery and veins of the forearms, whereas the ellipsis system exclusively is around the level of the proximal radial artery near to the elbow. So there might be more flexibility with the wavelength system. What you've seen in the videos and what I've tried to explain is that once you join that deeper vein and artery together in the proximal forearm, because of the perforating vein being there that sends flow up to the superficial veins, you have a result where this arterial flow that's now running into the veins can split and feed multiple veins in your arm, the upper arm cephalic, the basilic, the forearm cephalic. And so you get this network of lower flow rates going through multiple vessels rather than a single vessel. And this might actually give more cannulation options for patients. Perhaps with the low flow compared to just a standard surgical fistula, you possibly would end up with less of an unsightly, tortuous fistula that can be expected with surgical ones. This is what the fistula creation looks like angiographically once it's done, but perhaps more importantly, what it looks like clinically. This is 2 weeks after an endovascular fistula creation, and you can see here we've got prominent veins that can be used for dialysis, but it's not just one vein that's been created. You can see that there's a number of veins that are opening up that could receive needles at varying points. So there's increased surface area for needles. These are some endo-AVFs over the course of time, showing you the considerable less disfigurement associated with the endovascular fistula creation compared to surgical creation, with increased flexibility of where needles can be placed. How about outcomes? In some of the early literature we've got, well, one of the very first trials to look at the impact of endovascular fistula creation looked exclusively at the wavelength system. This was the NEATS trial. And what this showed is that there was 98% procedural success, but more importantly, 91% of those fistulas created did mature to potentially be used for dialysis. If we then have a look at what happened to those endovascular fistulas over the course of time, we can see some really good patency rates out to a year and beyond, where the primary patency rates were nearly 70% with the endovascular fistula. And although there were interventions needed to maintain patency, that patency rate after interventions was as high as 84%. If you compare that to a surgical cohort of fistulas, and this was a meta-analysis done alongside this that looked at outcomes of surgical fistulas, you can see the outcome data was a little bit lower, with primary patency of surgical fistulas being 60%, and then the secondary patency, those working after interventions at 1 year, 71%. So quite a bit lower than the results we were seeing with the endovascular fistula creation. Since then, there's been quite a lot of experts using endovascular fistula creation techniques globally. A number of them have been presenting and reporting their data in the journals. And here are a few studies that have been reported over the last few years using the two different systems, the number of patients in each of the studies, and in some of those studies, some really encouraging data around functionality and usability of the fistulas quite early on, and the time to needling. More recently, there was a systematic review that looked at all of these papers to try and work out whether endovascular fistula creation could be a game changer. It looked at the outcome data at 6 months and 12 months and found that it was very encouraging for these endovascular created fistulas. But the conclusion was that although it appears to be a system that's effective and safe and with good outcomes, because there hadn't really been a lot of head-to-head comparison with long-term surgical fistula creation, no one could say just yet whether it was truly superior or not, particularly given it's a fairly new, novel technique. More recently, Nick Inston and the Birmingham group have published a study looking at a comparison group of surgical fistulas versus endovascular created fistulas in their unit, and they have actually found that although technical success is similar in the two groups, when you start looking at the outcomes at 6 months and beyond, the endovascular groups appear to be doing better. So that's led to the possible pathway of how we might bring endovascular fistula creation into everyday clinical practice. We, particularly given that there is a cost associated with the process, we have an algorithm now where, if possible, we'd look to make fistulas at the level of the wrist if we can do that. But if not, before jumping to making a fistula at the level of the elbow surgically, there should be some consideration as to when an endovascular fistula could be created in the first instance. If it can, we should look to do that. And that still gives us the opportunity longer term to make fistulas in the upper arm surgically, even after endovascular creation has occurred. So as I bring all this to a close, I think what I want to say is that an arteriovenous fistula still remains the best way for patients to dialyze if they opt to have hemodialysis and there isn't transplantation available. We know from literature long term that surgically created fistulas are associated with high failure rates. And even when you get fistulas to work, they do require interventions to maintain their functionality over the course of time. The endovascular fistula creation technique is a new technology. There are 2 devices available that work in a similar principle where they're looking to join the deep artery and vein of the proximal forearm together to enable flow to run through a perforating vein and create an arteriovenous fistula network in the arm. The data surrounding these is very encouraging with lower reintervention rates. And what we see in patients with this low flow network of fistula veins is greater area to put needles in and possibly greater long-term data around outcomes of these fistulas, although we do need more data to make conclusions. There is a big upfront cost with making endovascular fistulas that's being worked on at the moment, but it may well be that in the course of time, we find that these upfront costs provide a cost saving compared to all the interventions that are needed for patients, not to mention the huge impact on patients of constantly having surgical fistulas created that are potentially prone to failure. So I leave it there. I hope that's provided some insight into new technologies in making access and the importance of access for you, and look forward to some questions with you now.
James, thank you very much. Very informative, and I think in layman's terms as well. So talking about this new technology, if patients wanted this method, is it available and where?
Yes, it's available. There are a number of centres that are using the technology. My friend and colleague Nick Hinton and Rob Jones in Birmingham have probably got the biggest experience in the UK. We're doing some in Oxford. Oni Jafar is doing some in London. So there are increasing numbers of centres in the UK that are using this technique.
So do you think in years to come, this is going to be the preferred method?
I think it probably will. I think we'll probably always look to see whether we can make a fistula at the level of the wrist first, conventionally. But I think before we go to making fistulas at the elbow region surgically, we will look to try and use this technology in patients if they've got the perforator vein that I described available, because I think they'll have better outcomes by having a lower flow network of veins that you can put lots of needles into.
So does this work with someone with small veins?
So it's a bit like a surgical fistula. You still need to have a vein of a certain size, and we know from lots of the literature out there that your vein ideally needs to be a minimum of 2 millimeter diameter at the time that we create a fistula if you've got a high chance of it being successful in fistula creation. So we still have a requirement that both the perforator and your main veins need to be around that 2 mil, but as long as they are, there's no reason not to attempt to try and make this fistula.
And John has put, what is the risk of leaving fistulas in stable transplant patients in the terms of cardiac function and the risk of bleeds if damaged?
Yeah, so that is a great question. It's one we're constantly debating in the access community. And in fact, this past year, most of the virtual meetings I've been to internationally, we've been talking a lot about long-term effects of fistulas on patients' cardiac status. And we know that when you've got a high flow fistula, and many patients are having their fistula flows measured on dialysis, if it's high flow, that can have impact on your cardiac function. The general view we've now got in the post-transplant setting is If you've got a patient who's got really difficult access, it's really difficult to bleed them and get blood from them, and they've got a working fistula, I quite like to keep it because you can use that to do the blood taking and do the blood tests. But I think if you've got a patient who's got easy to access vessels, they've got an unsightly fistula, it's very high flow, and they've got a good working kidney, I have a lower threshold for tying those fistulas off and getting rid of them because I think that's more protective for patients long term. That's not a globally shared view. There's not lots of evidence on that, but that's just been my approach and an increasing approach from a number of clinicians now.
And Tracy's put on here, very interesting speech, thank you. Hope has also said, great speech, thank you. And that concludes it, James. Thank you very much for your time today.
My pleasure. Thank you to you all.